Okay, guys, we're live. We are in Mesa, Arizona. My name is Colin Rigney, and I want to welcome everybody to tonight's call. And this was part of our webinar series. This is a live webinar series, and Ryan and I had this idea, a couple months ago, to how can we add a little more to the community and just share our flavor with things, right? With these live teachings. And tonight we're going to focus on the elbow. But first, I think we'll introduce ourselves a little bit in backgrounds. My name is Colin Rigney. I'm a physical therapist from Phoenix, Arizona, and I have a background as a professor at A.T. Still University, business owner here in the Valley, sports medicine, physical therapy office. And this idea of advanced musculoskeletal ultrasound center came to life as we began training our doctors and our physical therapists in our company. And we had to establish a system in order to scale across multiple locations. And we figured that, this is a system that can be applied no matter where you are. And, we've done this, we just have a lot of passion for what we do. And, this series tonight, we'll get more in depth with what we're going into. But again, just want to thank you all for spending the time with us and taking the time over this next. We'll take about an hour tonight, but obviously with Q&As and that sort of thing, we want to definitely keep it live and really just, engage everybody. And if you have any questions as we're going in, definitely throw them in the chat. And then, Ryan, why don't you throw in?
So Brian Martin here, super happy to have everybody on the line. I saw there's quite a few people out there. If you're listening, just drop in the chat. Where are you coming from? So are you somewhere in the U.S.? Are you outside the U.S.? Why don't you drop, in the comments there? Where's everybody coming from? We'll check out and we'll give some shout outs to some people. So yeah, Ryan Martin, I am a physical therapist by education, obviously MSK Ultrasound specialist. So my flavor is teaching MSK Ultrasound. We've been doing this for a long time now, really. We teach all over the nation. We've been doing these webinars. These webinars are really designed for you. We enjoy them. We have fun with this, but we set up the shop here. We bring in a model for you guys. This is all for you. And the reason that we do this is ultimately because this is a passion of ours, but we want to see this grow, right? We want to see this community grow. And right now, it's starting to flourish. And if we can bring everybody that's on this forum, this webinar, and reach out to your friends that are interested in this, and what we're going to do is we're going to get this interactive community of people that are learning and growing together. This has been kind of our dream for like 5 years. When we started in a surgical center, said, well, what are we going to do with this camera? I don't know. Let's make a class.
Yeah.
So anyway, that's me. And this is Colin. Tonight, we're going to be doing the ultrasound of the elbow. Like I was saying earlier, we brought in a model that we can be checking out the elbow, a former pro football player. So he may have some disrupted issues in that elbow. We'll see.
We'll find out.
We don't know. This will be the first time we've scanned it. We didn't do a test run. So what you see is what we see. It's all new to us.
Yep.
So any banter, any comments, any jokes, anything good lately?
Well, yeah, but let me start with our mission, guys. Our like Ryan said,
I want to start with a joke. Okay, fine. We'll start with the mission. It's priorities.
Our mission is any clinician who sees patients with joint pain, musculoskeletal pain, should, at least at a base level, understand how to use ultrasound in the office and be able to communicate to the patients. It's just an extension of your clinical brain. And this whole setup here is designed to engage, enrich, enlighten those of you who are maybe still wondering about ultrasound. Maybe you at a certain stage you're already doing ultrasound, or maybe you're a little bit more advanced, right? And we can just add to whatever level you're at. But that's really the mission is with our programs and our education system to add to the community. Doesn't matter what level you're at. If you're seeing patients who have those joint pains and conditions, learning how to use ultrasound can really elevate the standard, and really elevating the standard is really what it comes down to.
So that has been our mission from the beginning, is let's make sure that not only are people understanding and learning MSK ultrasound, they're learning at the highest level. And not only that, is they're learning how to integrate that into a current practice or an upcoming practice, right? Because let's be honest, a lot of people can teach how to scan.
Right.
But what do you do with that information is what we're teaching you here.
How do you apply it?
Yeah. How is it applied? So without further ado, you want to get going on this? Do I got any? I got plenty of jokes, but I might throw them in during the session. I want to get this scan going. I know everybody came here to see ultrasound. They don't want to hear my jokes. That's on my comedy stand up later this evening. So same time, same place next week.
Okay.
All right. So we're gonna go ahead and bring our model in here.
All right. Come on up here. What does that mean? So we're gonna have you lay on your back. We're gonna use your elbow.
Yeah.
So everyone, this is Julius. We want to thank Julius for his time tonight and donating his elbow for the cause of science and to further our learning. So I'm going to start with regionalizing this joint. So in the elbow, was broken down into 4 quadrants. We have the anterior, the medial, the lateral, and the posterior. Generally, from a clinical perspective, you're going to focus your exam to the region of concern in terms of what you're clinically suspecting. For tonight's purpose, I'm going to run through just base level protocols for all 4 quadrants, and I'm sure we're going to deviate, as some Q&A, as some questions come in, and I think we have some, Q&A trivia things planned as well, and we're going to engage you all in as we go with the anatomy. So to start off, we're going to start with the anterior section of the elbow. And
let's give a shout out to Catherine Barr coming out from Pittsburgh. All right, thanks for coming out. We got Northeast Arkansas from Jim Ferris.
All right. Hey, Jim.
Ryan Miller coming in from California. Oh, we got people coming in from Canada. This is great. Sharish, good to see you in here from Indiana. All right, go on. Let's hit the scenes.
Yeah, and also too, if you guys wouldn't mind, throw your level of experience with ultrasound in, whether you have none, a little bit, novice, intermediate, advanced. That would be great as well. So as we navigate here, as you can see, my probe is positioned cross-sectionally to the roughly in the antecubital fossa, and I'm going to freeze the transducer. Let's start off with just orienting ourselves. So we are cross-sectional at the antecubital fossa. When you're reading an image, the first line on the bone, so if you start on the bottom of the screen and you just fix your eyes up, the first thing you should see is bone, which is this bright white line right in the middle. Okay, and you see it's kind of double edged here. This is hyaline cartilage of the distal capitellum. This is kind of our home base in the anterior elbow. The big muscle right adjacent to the bone, that's the brachialis. And on the top is the biceps brachii. Let me see if I can have a cursor here. So biceps brachii is on the tip top here. This is the most anterior facing, most superficial structure at this section of the elbow. Coming down this whole thing, this is all brachialis. And I was describing the distal capitellum from medial to lateral. This cortical outline, that's the bone. And then this dark line you see, that's hyaline cartilage. Hyaline cartilage is high in water content, which is why it's dark on the ultrasound, similar to muscles. How muscle it's a hydrated structure, so it's going to have a mix of hyper and hypoechoic echo texture to it. Now I'm going to unfreeze. And now let's navigate. Now that we have kind of our central structures lined up, I'm going to move a little bit medially. And I'm going to pause. I'm going to pause right here. and just draw out where we're at. So this is the brachial artery, this hypoechoic circumferential outline. This is the median nerve. This is all still brachialis. Brachialis is kind of like home base of the anterior elbow. And off to the medial side here, this is pronator teres. And we're still in short axis. Okay, so we're still getting our bearings. So now I'm going to go out to the lateral side. Laterally. So we're at the level of the capitellum, just proximal to the radiocapitellar joint. And let's orient ourselves here. Okay, we're still hyaline cartilage, distal humerus. You're looking at the radial nerve right here, where the arrow is. This is all still brachialis, medial to it. And then over here, this is all brachioradialis muscle. So Ryan, would you mind doing a quick recap on the whiteboard and drawing the pyramid triangle?
Yeah.
So
let me walk over to the handy dandy whiteboard.
A quick chalk talk before we move on. I want Ryan to demonstrate just in written form, because learning takes multiple forms. How this breaks down. So if you're an analytical person, if you're a visual person, and if you're new to ultrasound, maybe this isn't the best representation to learn. So I'm going to have Ryan draw out what we call the anterior elbow pyramid and go through that diagram.
So when we're talking about the anterior window, we have a couple components, and people get stuck in the weeds all the time. So they're wondering, all right, what's anterior? What's medial? What's lateral? What's superficial? What's deep, right? So we use this triangle all the time to kind of break this down for all of our residents, for people that we're training. Even when we're talking to patients, sometimes showing them a triangle on a piece of paper and showing them, hey, this is what we're looking at and this is what is injured. It makes it so much easier. So this representation here, so we're going to look at just making a triangle here. All right. And so we're going to say that this is going to be the lateral side and this is going to be the medial side. Okay. So we're all in reference that this is the anterior short. I've never written. That's my sideways running. Okay. So this triangle represents all the borders within the space. So at the peak of this triangle, we have the biceps tendon, right? So we have that big biceps tendon right on top, right through here. The meat of this entire structure in here is the brachialis muscle. So we're going to call that the BR, right? So if this is the lateral side, we got a little nerve here. We're going to have a little nerve here. On this lateral side, this muscle space all through here is going to be brachioradialis. So this is brachialis. This is going to be B-R-A, what? D? Rad.
B-rad.
B-rad, whatever. This is the brachioradialis, okay? And so on that medial side, we know that that's the pronator window. That's where the pronator teres. I think we can just write PT, right? Yeah. Now the base of this, so right down through here, this is going to be your cortical space, right? So when you have that distal humerus, you're going to see this cortical outline with the hyaline cartilage on top. So it's going to look like a little McDonald's sign right over through here. Okay, so if you have on the radial side, what nerve is going to be over here? I know you guys are going to all write it down. Okay, on that radial side, I think it's going to be the radial nerve. I don't know. What do you think? Okay, so on the medial side, the medial nerve? No, the median. The median nerve. Okay, so right through here, this median nerve is going to cut across. It does end up in the carpal row. This is the triangle. This is what Colin's explaining on the image there. If you guys just take a snapshot, here, take this snapshot and save this for later. If you want a copy of that, I'll draw it, I'll sign it, and I'll send it to your house. All right, Colin, back to you.
Thanks, Ryan. So there's and we didn't coin this phrase. I think it was first time I heard it was Dr. Patel. Bone is home. Whenever we're navigating an MSK structure, and if it's adjacent to a bone, that should be your first point of fixation for fixing your probe to the area. Okay, so notice that was the first thing we did in the anterior elbow here. Okay, and it won't be the last thing we do today. Okay, so bone is home. So if you're new to scanning, or if you're just getting started or thinking about getting started, you don't know where you're at if you don't have a good bony landmark, or you're not optimizing, you're not getting the most optimal image that you can. Okay, so that's our home base orientation. So now we had a couple questions to go through the bicep brachii insertion. So throw it in the chat. How with ultrasound, let's see how many people know how many different windows can you visualize the biceps insertion? How many different windows are there to visualize the biceps brachii insertion? Before we get going.
Okay, I'm going to stop for a second. I'm coming over here. I'm coming into this one. We're going to talk about this real quick. So how many windows? All right, so hopefully everybody's putting into the chat how many windows they see. You can visualize the distal biceps, right? And there's going to be debate on, I don't know if it's debate, but there's going to be discussions about which is the best window to see the distal bicep as it attaches to the radial tuberosity, right? Now, some may say it's the anterior. Some might say it's the medial. Some might say it's a hybrid of the two. So, Colin, what's your favorite window?
The red team.
Red team, go.
No, so you have to learn how to do all of them. My first go-to is the anterior. The reason why is if I can get a good anterior window, I can see the largest footprint from distal to proximal. But it doesn't start and stop there. So Ryan, go ahead with your next one there.
So the medial?
Yeah.
So the medial window to me is when you're looking at from an oblique angle, what you do is you just follow the biceps straight down until you find bone. Bone is home, as Colin was saying earlier. Once you find bone is home, you sweep distal, proximal until you see that band. Once you see a brachial artery, the brachial artery through there, you know you're right at the right place. Mm-hmm. And Colin's going to show this to you. But what I've noticed is when you see it in textbooks, it's a 90-degree angle. They come straight down. That's your medial window. What I found is if you come slightly out, almost into an extended elbow, and you go oblique, so instead of coming full medial and full anterior, you're actually hybrid right in between. I found that you can get the entire footprint that direction, and anybody who has a distal bicep injury, getting full extension can just be a pain within itself. So having that light flexion of the elbow, oblique, and somewhere hybrid in between anterior and medial, that's my favorite. That's what I teach, but you have to know all four. So there's two more windows.
What's the advantage to medial compared to the anterior in terms of static versus dynamic?
As far as like being able to test it, yeah. I mean, you can test it.
Right. Well, which one's more optimal for dynamic testing, medial or anterior?
I would go with medial.
Medial,
yeah,
right?
You can test it easier dynamically through here.
Yeah. So if there's any question, like maybe there's your anterior window is inconclusive. There's a lot of fluid there. And it's not necessarily evident that it's you're not calling whether it's a full thickness, partial thickness, whatever. You can go to your medial window and do a little dynamic pronation supination to flesh it out. So let's go through these windows. The anterior window, like we're discussing, I typically start here, and I think we won't have an issue with getting Julius to the anterior window. So a good scan tip, guys, is patient position matters for this one. I get it. If they're super symptomatic and you can't supinate them because of an injury, or if it's acute or chronic, you might be limited in this window. And then thankfully we have the other three. However, if I can get this position, I'm going to start here. I'm going to get full supination, full elbow extension. And remember that this bicep kind of curls down and dives down away from you. So you have to accommodate a little bit by tugging the transducer in. And so bone is home. And the first thing I go for is, now I've done this a lot, so I just landed right on it, but the structure we're looking at on to the bottom right is the radial tuberosity. So this is all radial tuberosity. The anterior window, and I still don't think I'm getting the full footprint, but here's the full footprint. Now this is super deep trivia, but the two heads of the brachii, the biceps, the short head
comes off and inserts a little further distal and superficial. The long head comes off, and you see some of these fibers diverging here. This is your long head attachment to the tendon bone. Okay. And as Ryan mentioned earlier, this is one of the more difficult scans to learn in terms of technical skills. It is very much a hands-on skill, but if you have the willingness to put in the reps, is something you can acquire. Okay, so like Ryan said, we see this brachial artery, you know you're right in the vicinity. So now the brachial artery sits a little bit medial to the bicep, so I'm going to come on just lateral or radial, and it slips me right to the bicep brachii. Okay, so this is your anterior window. And you can track this proximally. And you see the steep dive it takes from the antecubital fossa to the radial tuberosity. And so when you're hunting for if it's a tear and a retraction, it's kind of a variable between will the lacertus be tacking it down and it's not retracted all the way up, or sometimes it snaps up to the cubital fossa like a rubber band. And that's very much up to you to go figure out and find. So that's our anterior window. Okay, now let's go to the medial window, and we're going to compare and contrast the dynamic element to this one. So like Ryan said, if you look in the textbooks, you're going to see the medial window patient position looks something like this. And I'm in agreement with Ryan that I think it's a little bit easier, and especially if they're symptomatic, I can get them here and kind of rest them a little bit. And the muscle group I'm using as the acoustic window to visualize it is the pronator teres. The medial window, aka the pronator window. So let me go a little more depth here. How are we looking on the ultrasound?
It's looking good. Some people are asking to zoom it in, but we got what we got.
Yeah.
Next time.
Yep.
But I'm zoomed into Julius's elbow. Julius, how we doing over here? We hanging in there? Solid. All right.
Julius had a long day today. I think he's ready to catch some Z's when we're done.
Everybody give Julius a hand clap or a thumbs up for being here.
Yeah, this guy works a lot, guys. He's very nice to donate his time here tonight with us.
Oh man, you're getting a lot of love over here, Julius.
So let's freeze it up. And the type A perfectionist in me is sitting here trying to get the perfect picture. So radial tuberosity, and as you can see, we're not getting quite the same area footprint. Now I can mess around and probably get a little bit more from the footprint width, but this is the bicep brachii. Okay, and this is the radial tuberosity. So I'm going to unfreeze and then demonstrate to you all the dynamic element to this window, which is super crucial. So if you want to see if it's actually intact or not, okay, you see the movements I'm making is just itty bitty movements. You're not cranking them all into, super high range. Okay. You're not going to be able to track the movements as well. So I'm just going to take these little movements, these baby movements. So you see the radial tuberosity is, I'm pronating, supinating the forearm, and you see that tendon gliding just nice and crisp. And so I'm tracking. And the brachial artery is kind of my guide here. That's a nice picture. Okay, so right underneath the brachial artery, you see those tendon fibers gliding, and I can track it right to the radial tuberosity. Okay, so now let's go. What are the other two windows? The other two windows are the lateral and the posterior window. Each has its own advantage, let's say.
the lateral window, you're not going to get a nice clean tendon bone image, but what we do get is, again, it's a good dynamic window to test if whether or not it's intact or how high grade is it a full thickness or partial. This is a good window to help you confirm that. In order to acquire it, okay, patient position matters. You see the patient position here, belly on their lap, rested about 90 degrees on the elbow. So how we're going to find this, okay, I want you to start a little further distal on the forearm. You see how I'm short axis here? And then you see the bone right in the middle. That is that's the radius. Okay, I'm going to move upwards, superior proximal, and that's the supinator. Let me use my arrow. Short axis, radius. This is the supinator adjacent to it. And this is all brachioradialis up here. Okay, so now I'm going to move proximally, just ever so slightly. And boom. You see this bright structure come in on the bottom? That's our bicep brachii. Okay, you see, because of the shadowing of the radius, we're not able to get to the tuberosity aspect. But as I said, the purpose of this window is not necessarily to assess the tendon bone interface. It's to assess whether or not this tendon is intact or not. Okay, so again, I'm going to take his hand and just do a little pronation supination. Nice. And you see no paradoxical motion. That thing glides like on a string. Okay, just how it should. So remember the method for that one again. Okay, start distally on the forearm. Find the radius. Slide proximally until you see this tendon coming in horizontally. Okay, and that's a fail-safe way to get the right picture every time. Okay, so the medial and the lateral windows are really nice dynamic confirmations of the bicep brachii. How intact is it? The anterior window is probably your optimal view for tendon bone footprint. The medial is probably a close second. You can get some arguments on that, but the posterior window this is the window if you're a physician and you're doing orthobiologics, you're doing PRP injections. This is the window you're going to use to guide your needle to the distal bicep insertion. The reason why this is because we can avoid all the neurovascular structures and landmines that fall in the way of a needle potentially if we try to go anterior medial. So we eliminate all those things by using the posterior window to do a distal bicep injection. Just like the other positions, okay. Remember, biceps is as much of a supinator as it is an elbow flexor. Okay, so we're going to put this patient on pronation. We're putting it on slack in order to expose it out from the forearm. Okay, and again, the patient position, we're full pronation. I flex the elbow. Now, I'm going to go short axis to the forearm. The bone that's highest up on the screen on the top right, that's the ulna. Okay, so you see where I'm at. I'm not really close to the bicep insertion at this point. That's intentional. This is a way to find it reliably every single time. So I'm going to start distally, and I'm going to sweep proximal now. And you're going to see the radius come in on the bottom left. Okay, now I'm going to keep moving proximal, just super slow. You watch my movement pattern. And that piece of tissue, that bright tendon right over above it, looks like a little bird's beak. Okay, that's the distal bicep insertion. Okay, and I can confirm that by pronating and supinating.
So give me a thumbs up if that's coming across clear. And we've gone through the explanation well for the posterior window of the biceps.
Getting a lot of thumbs up here.
Okay.
And a lot of thumbs up.
And hopefully it makes a lot of sense for, if you're a physician, like I said, and you're doing these procedures, or even if you're a PT and you're doing dry needling and you want to stimulate some blood flow to that area, okay, this is the window you want to take. And your odds of doing this accurately in a blind manner are very low. So using ultrasound is really your best means to know you're getting to the right place. Okay, so again, last one, and then we'll move on to the next. Okay, so just to recap the posterior. Okay, start short axis, start more distal than you think you need to. The ulna is at the top right. Okay, I'm going to sweep proximally now. The radius is becoming more prominent. See the radius rising up closer to the ulna. And then once you see that bright coverage over the top of the radius, that's how you know you're on the biceps. And we confirm it by doing a little dynamic. Okay, so full pronation, all of a sudden, wow, I see that tendon come into view. And this is your bread and butter if you're doing procedures. You want to get really good at this. So I fell off it there. There we go. Okay. So what should we do next, Ryan? Medial or lateral?
Let's do lateral.
Lateral? Okay.
Let's do lateral. We can chat about it a little bit, and then I got a little whiteboard chalk talk.
Yeah. So I think let's go over a concept first. So the lateral elbow. What's the most common lateral elbow condition most people are going to see? If you're a clinician treating outpatient sports MSK injuries, it's going to be tennis elbow, right? Ryan, if you wouldn't mind breaking out the whiteboard, I want to just do a little conceptual visual on the lateral epicondyle and the structures to be aware of in this area in terms of how they interact with each other.
Let me switch my screens out here real quick. So now everybody's going to see us here. So it should be a big screen at this point in time. Give thumbs up if you guys can see my whiteboard. All right. So I love teaching with the whiteboard. Hopefully Colin's not in the way here. So what we see here, let's look at the distal humerus right through here. So we have the capitulum right through here. This is the capitular ridge from that lateral epicondyle. We have the radial head over here. So this is going to be long axis, right? And so what we're looking at in this long axis view is we're looking from, let's start from bottom up. This is how we were kind of taught here. From the bottom up, we have the joint line. This is the RC joint right in here, the radiocapitular joint. Just above that, you're going to have a little bit of soft tissue right through here, and then you have the radial collateral ligament. Above that, you have the common extensor, and then you have some subcutaneous. Now, something that we've seen in literature, and it's not exact perfect, but it's pretty darn close, is the 50% rule. So when we talk about the 50% rule, and you're having a hard time differentiating between common extensor and RCL, because the way that it's shaped in here, it compresses that CET a little bit. So sometimes they blend a little bit in here, and you can't always differentiate the two. So from that apex, from that emphasis over here, what you're looking at is this downward slope to right about where it stops and flattens out a little bit. 50% of that space right there, 50% of the top half is common extensor. The second 50% is going to be RCL. Another important place to be looking at is down in here. So after the radial head, there's this little space called the annular recess. It's a good pocket if you have effusion of the joint space. So if you're considering joint effusion, look down here.
Question. Does the radial-collateral ligament have an overlap component with the common extensor tendon?
I would think so.
Yeah. So this 50% rule is crucial, okay? But there is some overlap, okay? Meaning, I think there was a cadaver study over 10 years ago now that it was over 400, 500 cadavers. And a lot of them, like an overwhelming amount to comment on this, was the RCL component to common extensor tendinopathy shouldn't be underappreciated. So meaning the more deeper your tears are, the more deeper your pathology is at the more distal attachment of the common extensor tendon means you should start to consider possible radial collateral ligament involvement.
It's getting pretty
heavy.
Can I put it down now?
Yeah.
Sure.
He's like, just give me the cue, man. Stop talking. All right. All right, here we go. Okay, so patient position for this one, guys. This is my preferred position. It's not the only position. I think other people might, hey, we can go a little more rested, whatever. I just prefer here. Okay, this is not the one and only position. If you're just getting started, or my advice is whatever you do, learn to do it the same way every time. Create an internal system where you're going to be reliable with how you're going to be doing every scan. Okay, so this is the patient position. And let's optimize our view here. Let's go a little less depth. And as Ryan was mentioning, where's that focus?
Let me share that screen so everybody can see it.
All right.
Share screen. All right, everybody, when I put this screen up, give me thumbs up. Make sure that pops up. Anytime we mess with technology, it gets goofy. So
anytime Colin presses buttons.
Yeah, when Colin presses buttons, and we've decided he presses a lot of buttons. I'm getting a lot of thumbs up. All right, thanks, everybody.
Metaphorically or physically. So to the left, this is proximal, right is distal. So let's freeze this image quickly and just orient ourselves. So Ryan did a nice diagram of the structures. Hold on. Okay, so proximal, this ski slope, this is the lateral epicondyle. So draw a line roughly 50 at the 50-yard line. That's the differential between distal here. This is ligament footprint. At proximal, this is tendon footprint. Joint space, the radiocapitellar joints. This is the radial head. So you have some annular ligaments coming over here. Then the radial collateral ligament comes off of it to reside at this deep footprint attached to the distal capitellum here. We could spend another time going over a deep dive into ligamentous anatomy. There's a lot of offshoots and just not variant, but the way the radial collateral ligament attaches here, it's not just a one-way ticket. There's a lateral ulnar collateral ligament to be mindful of. We have the annular ligament bands that attach to some of the RCL, and there's an additional radial collateral ligaments that's a little more posterior that as well we should be mindful of in certain cases. But for now, I want to stick with just the general anatomy. So let's unfreeze and go back to the view. Okay, so as a general rule, tendinopathy is going to occur at the proximal aspects. More of your tears are going to occur at the tendon bone, at the distal attachment of the tendon. Okay, now let's go and really dial in the radial collateral ligament. So one sonography trick to isolate the tendon. How do I know what I'm looking at? Am I truly looking at the tendon or the ligaments? Because they both have similar fibular patterns. The RCL is going to be a little more posterior. So if you see my screen, okay, I'm going to move my transducer just a little bit posteriorly. And as soon as I do that, you see these fibers start to separate themselves a little bit. Okay, off the annular ligament, you see these fibers here. This is the RCL. Okay, and I did that just by coming a little more posterior. Now, this is a healthy specimen, so everything we're looking at looks pretty good. Radial head. Something I always check for as well, you see this triangular infolding between the two bones. So what I'm looking at is this synovial space here, this triangular structure. Okay, that's synovium. Okay, something I always check for in patients with lateral elbow pain or have a history of falls or contact sport athletics. This is the place where you're going to look for your loose bodies or synovial entrapments. And you see what I'm doing. I'm pronating, supinating, and you see that synovial fold. There's no disruption. There's no loose bodies popping out of there. I can go even a little more posterior. So you see how I'm coming further back, okay, to get a larger window into the joints. I'll just take an extra 30 seconds to come back here and look for it. And I'm always doing it dynamically. It's very hard to elicit if there's posterior, if there's loose bodies in the joint. You can really only get to it by dynamically assessing. Okay, so that's just one little tip and trick there. Now, as Ryan mentioned, the annular recess is this radial head neck junction. So now we're getting into kind of the next section of the lateral elbow protocol. So let's freeze. Radial head, neck junction, then the shaft of the radius. Okay, this muscle is the supinator. And then we're really close to the radial nerve. This is some radial nerve fibers coming over the top. When there's joint effusion, usually it's secondary to possible fracture, maybe some acute synovitis. Most commonly, if there's a history of trauma and you suspect a fracture, you should always look at the fat pads in the recesses for fluid to accumulate. So this is just a key area to be mindful of if the patient comes in fitting with that kind of history. Okay, so coming down, here's our supinator, and then tracking the radius kind of distally midway to the forearm. Okay, that's my longitudinal exam for the lateral elbow structures. Now let's go short axis.
Julius, do you need a water break?
All right, stay hydrated. Okay. So let's go short axis of the same structures. Let's just review. Whatever you take in one view, you should look in two. So here is my common extensor tendon, lateral epicondyle. I'm going to turn it short axis now and visualize the tendon bone attachment in cross section. This is the lateral epicondyle. Then this structure here, it's kind of ovoid structure, pancakey-like structure. This is the cross section of the common extensor tendon. And you can break down the digitations to extensor digiti minimi, indices communis, extensor radius, radialis brevis, and longus. If you want to go that deep. Now, the most common tendon involved in tennis elbow is the brevis. And it's usually right kind of, if you're drawing a cross-sectional line, you kind of see some of the digitations right now. But if we draw a cross-sectional kind of boundary, let me freeze. Generally, you're going to see most of this is where your brevis sits, right here. So you see this tendon outline? That's the body of the brevis. Okay, so it's really kind of more anterior facing. So that's our short axis of the common extensor tendon. Let's go to the radial head. Now, I'll generally do just a quick dynamic here. So I'm looking now at the radial head. This is this nice convex, nice crisp white convex structure on the top. And the annular ligament sits right adjacent to it. We're looking at the annular ligament now in, technically this is long axis of the annular ligament. Radial head, annular ligament, this bright structure here. And I'll do a quick dynamic check. Take the wrist. I'm looking for any jumpiness. Does it stay in one place? Does it move up superficially with any dynamic movement? Is there any loss of convexity anywhere? Is there any non-uniformity in the bone? Those are all things I'm looking at. And I can go a little more posterior to it. As I come further back as well, that's the ulna to the right. Okay, so you're looking at the junction there and the quality of how those bones are interfacing with each other. Okay. Now, let's spend a little time on the radial nerve. Everybody still with us? Julius?
Yeah.
Right. Okay.
So before you get going, we have a question from Jim Ferris. Hey, Jim, how you doing? Hey, what are your thoughts about a patient with point tenderness over the common extensor tendon who cannot supinate more than 60% of the contralateral forearm without pain? So what are you thinking? What's your first go-to running diagnosis for a patient that can't supinate and has point tenderness over the common extensor?
Isn't there a syndrome with the name supinator in it?
Could be. That'd be my first go-to. It could be a supinator syndrome, but then again, you always have to check the joint line. Is it not supinated correctly? So there's a couple other.
Is there mechanical blocks, that sort of thing?
Yeah, the mechanical block, or is it myotendinous? Or, to me, when I see those kind of things, I tend to look at supinator syndrome. I also look to see if there's any radicular symptoms, any neurogenic type factors to see if the PIN or the superficial radial nerve has been entrapped. I think that's what we're going to be talking about right now.
Totally.
Perfect timing,
Yep.
Jim.
So let's track the radial nerve. Okay, this is the position I start. I always start in short axis, and I want to start kind of at the distal humerus. So let me get my bearings a little bit here. I'm going to go a little more depth. So you see where I'm at? Right here with the transducer. I'm going to freeze quickly. So I'm at the distal humerus, kind of laterally. Okay, so remember the nerve comes out from the armpit, then it wraps around from posterior around the triceps to anterior, and it comes out of this bony groove, this osseous groove in the humerus called the spiral groove. And as soon as it exits there, it makes it course anteriorly. Then it comes down to the antecubital fossa, and then as it enters the supinator, it bifurcates into its cutaneous and motor branches. Okay, so that's what we're going to track right now. So distal humerus. We're in short axis. Right here is the nerve. So it's just one circumferential hyperechoic kind of mixed bundle of grapes looking structure. Okay, so now we're going to track it. So as we go distally, I'm approaching the distal capitellum. Do you see how it's starting to turn into what has been coined the snake eye view? So it's still one perineurium, okay, but it's beginning to now move into a split position. So now we're at the distal capitellum. This should look familiar. The hyaline cartilage coming over the top. Okay, now as we move distally, you see some structures there. You see a beating structure. This bundle of vasculature here. There's a term for it. It's called the leash of Henry. This is as it's starting to enter. This is a common point of entrapment. As it's approaching the supinator, this is one point of entrapment that one should consider in cases of supinator syndrome. Okay, so as we're moving down, the split starts to occur. This is the split. And I'm going to backtrack in a sec, but I just want to point something out. Here's the radius. This is your supinator. Okay. This is this little thing right where the arrow's at. That's the posterior interosseous nerve. The anterior cutaneous is still up here. So you have the deep head of the supinator and then the superficial head of the supinator. The posterior interosseous nerve splits the two heads of the supinator. at the arcadophrose. So there you have the two structures that are common sites of entrapment, the Lecia Henry, the arcadophrose, and they're right, kind of, I believe arcadophrose is a little bit distal to the Lecia Henry. Ryan, you can correct me if I'm wrong on that. Okay, so we're back. Now we're going to track, and do this in real time.
We'll see.
There's your that's your posterior interosseous nerve splitting. Okay, so let me come back. Okay, here. Split. Now it's going to come splitting between the supinators. And that's where we are. Okay, so now you see where I'm at on the forearm. This was a hard one to narrate live. The ultrasound is very much a hands-on skill, so definitely love to get a chance to work with more of you, and we'll share more about how to get a hold of us if you want to inquire what that means.
Well, also, while we're online, I sent a poll. I sent a poll out for everybody. If you're interested in an elbow scanning and injection technique online course, I'm doing this right here. I have not asked permission from Colin, but I heard sometimes it's better to ask for forgiveness than permission. I'm going to give you a 25% discount on our elbow scanning course if you want to get that, guys. So I'll drop a 25% off of the elbow scanning course if you want to do that online.
Okay, so let's go to the long axis radial nerve. And this one's a little bit easier to pick up the split in long axis than short. There's a couple different ways to look at this. So if you see me waffling between positions, I'm deciding which one I want to show you first. Let me start with this position. Okay, because I like to use this window. So I'm kind of using the brachioradialis as my viewing window to watch where that radial nerve splits off. Okay. And as you want to track the posterior interosseous nerve distally, this is the best. It's going to track more like this. Okay, it's going to track more on the dorsum of the forearm. So the annular recess is kind of my lighthouse here. Bone is home for me here, and you see what I picked up. First thing was this. See this Y right in the middle. This bifurcation here, this is your posterior interosseous nerve, superficial nerve, splitting the deep head of the supinator, superficial head of the supinator. So one view is no view in sonography or any radial or anything in radiology really. So which is why we use these multiple views. So this is a little bit easier one to acquire. When you're first learning tracking the radial nerve in short axis, watching the split, definitely takes a lot of brain energy, but it can be done with the right reps and guidance. But the long axis generally is a little bit easier to pick up in the early stage for people. And you want to track this. If you want to track the posterior interosseous nerve more distally, okay, it's going to spiral. So watch how I'm spiraling. I'm kind of tracking the nerve. Here we go. It comes back here, okay? And we can, you can theoretically track it all the way down to the hand. Let's see. The other view, so for our injectors out there, this is probably the view you're going to want to use if you're considering doing any procedures around the area, freeing the radial nerve up from the Lecia Henry, the arcadophrose. This is probably your best window for that. The reason why is you can clearly visualize the vascular structures in a way that you really can't do on the other side. So let's demonstrate what that looks like. Because in order to be a good interventionalist here, you have to know how to navigate with the ultrasound. And to be more than just competent, it requires a lot of reps.
just so you know, Colin, everyone that answered, there was 24 people who voted for people who wanted the injection course. Our assistant Torero. So, hey, Torero's online with us. Can everybody give her a round of applause for kicking some butt back here?
Thank you, Torero.
Yeah, Torero. She's already putting together a coupon to everybody that responded to that for your emails. So, all right, guys, everyone's going to get that. Anybody who responded to that is going to get a 25% discount for both a live scanning course and for an elbow lecture course, both having continuing education. All right, sorry, Colin.
No problem. Okay, so let's find the radial nerve and long axis. Radial nerve and long axis. What I look for familiarity here is I'm looking for the area where there's vasculature. So we can turn on the color. If I decompress a little bit, okay, we're getting some vascular signal. And this bright white structure right above the vessels, that's our radial nerve. Okay, we can find there we go. So these bands of vessels that have a tether or a vincula attachment to the radial nerve at this level. The cause in the genesis of supinator syndrome is those vincula and this confluence of vessels in the area can cause restriction and compression to the radial nerve. And so you see clearly both the vessels and the nerve. And if you're looking to free this up with some water, okay, this is your best view. Yeah. This is your best view, and you're going to take the distal to proximal approach with your needle in the lead up to a procedure like this. Okay, but before you even consider it, you have to be able to find it with the transducer. Certainly, I think if we have more demand for, like, hey, what are the most common pitfalls for like common procedures out there, or even complex procedures, I think we'd love to hear a list of what you all may have and anything we can help with, and put together maybe a special webinar based on those lines of questions. So appreciate all your feedback, guys, and for everybody still with us. We're navigating right on through. So let's see, how much time do we have? Just a few more minutes. Okay. So let's go quickly to the ulnar, the medial side. Why don't you lay on your side and face me?
So what is the most common pathology that we tend to find in the medial side of the elbow? So go ahead and throw that in the comments box. What is the most common pathology that we tend to run into on that medial side? So everybody just go ahead and throw that in, and Colin, you can just start your lecture.
So patient position, I prefer this. I prefer them laying on their affected side facing me, provided they don't have any shoulder issues and they can accomplish it. If not, I can kind of get you to kind of like slide out from under you. You okay? Yeah, get up there. Okay. Okay, so this is my patient position. Now I can manipulate the elbow a little bit better than if they're supine and just kind of like this and cranking. This is, I found, to be a little more comfortable. So I'm going to evaluate the common flexor tendon with the elbow in extension. Then I'm going to isolate the ulnar collateral ligament by flexing the elbow a little bit. So let's start in the common flexor. So this is a bit of a different animal than the UCL. So the common flexor. Shorter footprint. Okay, it doesn't quite have the same footprint width. Distal to proximal here. This is your common flexor tendon, and the pronator bundle sits a little more anteriorly. Down here, this is your ulna. Okay, you have ulna's down here. This is a joint. This is the trochlea. We'll get to that separately.
So Delisa, And Balaji, they're saying that it's going to be that medial epicondylgia, that medial epicondylitis, or golfer's elbow. I think these are going to be some of the biggest things that you're going to see on that side. Another thing that you're going to be seeing, and we'll be talking about it, is the anterior band of the UCL.
Okay. Pro tip here and clinical tip with tears versus tendinopathy at almost any junction in the body. Most of your tendinopathies are going to be more proximal. Most of your tears are going to be more at the distal tendon bone attachment. Just as a general rule, it almost doesn't matter where you're at. So just file that one away. Okay, so we're at a common flexor tendon. I'm going to turn his short axis. We're looking at the same structure in the second view in common flexor. So now let's move to the UCL. And I'm being mindful of time a little bit. I'm not going to overrush it, but I think the UCL is probably what a lot of you came here for. Because if you see any throwing athletes or any overhead athletes for that matter, this is, as we know, a common injury.
I'm going to say switch hands.
Okay.
Good. The probe is in the, yeah, there you go.
Yeah. Especially here in Arizona with all the baseball we have. So I just went right to it. Okay. But for those of you learning, having trouble with finding the UCL with regularity, here's something that's helped me in my early stages. I find the shaft of the ulna. Run up to the head. Okay, if I could find the head of the ulna, now I'm good. That's my distal end. So I'm not going to move the distal end of my transducer. The distal end of my transducer stays there. Now the proximal end of my transducer is going to go this way. It's going to go more anterior. Switch hands.
Your other hand.
My other hand.
My hand.
What?
Your hand.
Like this?
That's it.
That's it. Okay.
I think a guy like this goes home with Starla. My other hand.
All right. Bad jokes aside. So distal end stays fixed on the ulna. The proximal end is going to shift anteriorly until you see this band of fibers come in. And your two bony landmarks are clear in the image. Ulna, sublime tubercle of the ulna. This is the ulnar collateral ligament. Okay. The scoop of the trochlea here, there's a little bit, this is fat pad. Okay. Right above it, this is ulna. In cases of acute tears, what you can see sometimes is displacement of the fat pad secondary to an acute or traumatic tear. Now, elbow angle kind of matters. There is some argument in the community on should the joint move, should it not? Is there a gapping? Whatever. Just as a general rule, if somebody has a history of throwing, they're gonna have a little more gappiness to their elbow compared to the normal population of non-throwers, and you should expect a little more movement in that population. I think anywhere between any movement difference in the gap between more than 1 millimeter should be a little suspect, and you're going to need to obviously correlate that. There's some other factors to consider, but I've seen a gap up to 2 and 3 millimeters, and when it does, that's definitely a high grade injury. So you're talking a 2-3 plus at that point if it gaps that much. I haven't seen a healthy elbow gap 3 inches since I've been scanning. Now we've done a couple. Yeah, if you 1 to 3 millimeters. Yeah. That's an objective measure. Okay, in some qualitative measures, or these are objective measures too, but more qualitative, is what does the cortical surface look like? Is this cortical surface look like Julius, where it's smooth and uninterrupted? or are there cortical irregularities where the ligament interfaces with the bone? Okay, that's a signal of potentially some chronic avulsions. Same thing with the ulnar side. Okay, less common on the ulnar side to see cortical irregularities, but at the sublime tubercle, we can occasionally get some of that. Okay, we're looking at the quality of the fibers. Is there any disruption? No, not in the static image. Okay, but that doesn't always mean it. Okay, so I'm going to go now, I'm going to take him into a little bit of valgus. So I'm going to gap the joint a little bit. And you don't need to apply a ton of force. Okay, you see there's like virtually zero movement here. Most of your non-throwers, there should be hardly any movement. And this is where the art comes in with ultrasound in the medial elbow with your overhead athletes. Because you should expect a little bit more movement there. And then you need to correlate it with their signs, symptoms, as well as the other more qualitative things that I just mentioned. Is the outline of the bone smooth? Is there any gappiness in the ligament as we stress it? That sort of thing. So we could probably do a whole separate masterclass just on the UCL. And again, if there's any demand for that, please let us know. We'd love to spend more time helping you guys out with questions that you have. This is why we're here. We want to provide value to the community and definitely engage with you all. So what else? Should we cover the ulnar nerve or should we go to the posterior side?
I would say let's do the ulnar nerve, and then posterior side we can cover if people have questions, because it's pretty self-explanatory.
Yeah. Posterior side is really easy and straightforward.
Yeah.
It's one of the more easier structures to learn. The tricep insertion, the fat pad, and the joint space back there.
I just want to give everybody a quick shout. Thank you, everyone, for hanging tight. We still have a ton of attendees. So this is the last structure. And hey, this is the thing. This is interactive. We want questions live. We want questions now. So if you ask questions, we're going to answer them for you right here, right now. So don't wait till the end. Do it now.
Right. Evaluating the ulnar nerve. We're going to start with the patient. Same position, sideline. I'm gonna extend the elbow. I'm gonna find the cubital fossa, the cubital tunnel, and I'm looking for two bony landmarks. My two bony landmarks are medial epicondyle, which is on the left, the olecranon, which is on the right, and this circumferential structure right in the middle. This is the ulnar nerve. Okay, we have a muscle here. This could be epitrocleris, or it could be a medial head of the triceps. Unsure right now. Let's get into some dynamics and maybe we'll see. So we want to evaluate this dynamically. Okay, is it number one is what are the symptoms like? What's their history? Is there that the typical mononeuropathy pattern is the neural signs into the ring and the pinky finger, tenderness in the cubital tunnel, as well as possibly some audible or palpable snapping that the patient can reproduce. So we can often find that with ultrasound.
Question here. Katie is asking, is there a normal size of the ulnar nerve? Like when we do the medial nerve, we know there's cutoffs and values. And I know there's literature out there for the
I think it's 8 to 9 millimeters squared.
So Katie, did you hear that? About 8 to 9, but let's go ahead and we're going to get you that information.
Fact check me. I believe it's 8 to 9 millimeters squared.
I think
it's an area.
I think it's worth a Google.
No. All right. So dynamically, because the subluxation and dislocation patterns are a dynamic thing, it happens when you flex the elbow. I'm gonna really focus on the medial epicondyle because that's where it's gonna snap over. So I'm gonna focus my transducer on the medial epicondyle. I'm gonna flex the elbow, and you see that nerve. Am I running into the pillow? We're good. Okay, you see the potential for compression here of the nerve against the medial head of the triceps there, but it's not subluxing or dislocating. It's staying in the groove. It has a nice stable ligament structure right over the top, which is, ooh, we've got a good ligament there. That's our ligament. Okay, so that's our dynamic assessment of the ulnar nerve. Definitely we can go on a whole lot more about this stuff, guys, but I do want to be mindful of everyone's time and certainly appreciate you all being here with us tonight and allowing us to share our passion, what we do. If there are any additional questions, for those of you who are still around and want to ask and you're not, we're not intruding on any more of your time. We're here to hang out a little bit and answer any more of your questions. So fire away in the chat if there are.
So yeah, everyone, anyone and everyone, let's hit some questions up here. We're gonna stay online here for a couple more minutes. I'm looking at the live feed right here, seeing if there's any questions. One thing I do want to recommend though is if you are getting into MSK Ultrasound and you're kind of at a roadblock to where you don't know where else to go for resources or you need to learn more, that's what Colin and I do. So we have the opportunity for a discovery call if you have more questions. Torero, if you're out there, can you put a link to maybe a discovery call if anybody wants that one? Or if you guys want to just go ahead and write yes, discovery in the chat box, we will get that sent out to you. So as soon as you sent that, we have your email saved into the program here. So if you just write in discovery, we'll go ahead and send that link to you, but we'll also post that link at the bottom, hopefully soon. I know Torero, just so everybody knows, Torero's in South Africa, and she stays up pretty darn late to get this done. So I want to give 2 massive rounds of applause. One also for Julius. Julius, give a who.
Thanks, guys.
All right. And then obviously Torero on the back end of this, making sure that this all goes. Here comes some claps here. I want to give another big shout to Colin. This is not an easy task. Doing live scans, on the cuff with all the technology going on in the background, this is not an easy task for us. But this is something that we love doing, and so we hope that you all enjoyed it. So let's give 1 more minute for questions. Anybody want to throw some questions at us? What ultrasound unit are you using this evening? That's a funny story. So if you have 2 seconds, everybody, here's the story for this ultrasound unit. This is a Mindray TE5. I love it. It's great. But it wasn't the one that we chose for the night. The one we chose for the night was called a Wisonic Clover model. So shout to Wisonic. We're not getting paid by any of these people. We had a Wisonic, and the person that was supposed to pick it up completely forgot. Me. So I didn't bring it. And so right before the webinar, I scrambled to one of our other clinics about 15 minutes away, and I grabbed this one here. So this is the Mindray TE5. I love it. The resolution is great. The only thing that we can't find is how to make it a full screen. We know it's capable. We just, we're too, well, I'll leave the adjectives alone. But we couldn't find how to do that. So if you guys have issues seeing the screen, we apologize. We'll have our Clover, the Wisonic, next time. Any more questions, everybody out there? Great training. Thank you, everybody. Thank you. Thank you. There's the discovery call in the box right there. Call us up if you have questions. Okay, everybody? Colin, do you have anything to end with?
No, just again, really appreciate you all. Without support and without people showing up to this, we wouldn't be here. And so thanks for allowing us to do what we do. We love what we do. And for us, it's certainly a lot of fun to teach and train as many people as possible to learn how to use ultrasound in the office. So certainly give us a call. We're happy to share about our programs, and we'd love to hear from you.
AMSKU. That's it. Simple as that. AMSKU, or click the discovery. Like I said, anybody who answered that poll that was interested in the elbow, we went ahead and we're emailing you a coupon for the live courses and for the lectures. So, and again, those are continuing ed. Those are AMA Cat 1. So that's the PRA. That's the highest quality you can get. It's almost like USDA, it's like prime beef.
It's like military grade.
It's military. I don't know if you want to say that. Military intelligence. It's good. Okay. They're good units. They're good hours. They're good continuing ed. Go get yourself some continuing ed and get 25% off. It's on Colin. He doesn't know yet, but
yeah,
he's paying for it for you guys.
Sure.
All right, so I just wanted to say thank you, everybody, for joining us. A lot of you hung tight. I know a lot of you are on the East Coast, so it's pretty late for you. You ever come out and visit to Arizona, come look us up. We'll take you out to dinner, okay? All right, everybody, signing out.
Thanks, everyone.